Actually, Masha really got me to look at, this is what I see all the time when I analyze my data, but to look into it a little bit further, the sex differences in liver cancer and hepatitis B are actually not subtle at all. We don't have to look far. So my slide is very simple. So what we have observed is a quite striking difference between male and female in hepatitis B as well as hepatitis B-related liver cancer. So if we read papers on hepatitis B, whether it's on treatment outcomes, the clinical trials, or a study on diagnostic tests, whatever, what we always will see is that 70% of the cohort is always going to be male. And in fact, it's one of the things that I would look first when I review data with my fellows or postdocs, to just see, how our cohorts can be generalizable, etc. So the same is true for liver cancer when we look at it. So when we look at liver cancer studies of whatever topics, again, we're going to find that about 70 to 80% are male again. And it has been shown again and again from studies, whether from the US, Asia, or Europe, liver cancer risk is clearly 3-4 times higher in male compared to females. So this is one disease that the sex differences is pretty obvious. It's not subtle at all. Okay, so why do we observe such differences? So this has been recognized for decades now, and it has been a topic of quite a bit of research. So people have asked, so are HBV-infected mothers more likely to transmit the HBV to sons, and maybe that's why we have more men with chronic hepatitis B. And this also was stimulated actually somewhat by the facts that there are just a lot more male newborns than females. And I'm going to go back to that in a little bit. So, and some other questions that people can ask is that, are male patients with chronic hepatitis B less likely to clear the infections, either spontaneously or with antiviral therapy? Or are they likely to have more severe disease? So these are some of the questions that have been asked and looked at. So before I go into the studies and experiments to try to understand some of these differences or explain them, I would like to just review hepatitis B briefly. And why is hepatitis B important? It is a very common infection. There's 350 million persons infected worldwide. That's a lot. And if we look at this map here, anywhere that with light green or dark green, that means that we have a 2% or higher prevalence of hepatitis B infection. And that pretty much covers everywhere except North America, Australia, and Western Europe. So that's the reason that the CDC and the US Preventive Task Force have recommended that anyone who comes from these areas that is light green or green here, we need to screen them for hepatitis B. So some review on hepatitis B. It is a DNA virus. It has actually a fairly complex serologic testing schemes and how we interpret them. And HBV DNA PCR is widely available and easily obtained and help us a lot in the management of patients with chronic hepatitis B. It's transmitted parentally, sexually, and vertically. The mortality for acute infection is very, very low. So people call it is a disease of the iceberg, or it's a silent killer, because most of the people who die of hepatitis B, not from acute hepatitis B, but from chronic hepatitis B due to liver failure and liver cancer. We actually have very good vaccine as well as post-exposure prophylaxis with HBeAg. So, we kind of wonder why we still have so many patients with hepatitis B. If we have that, it's because of the lack of implementations of many of these measures. And we have very good suppressive therapy for hepatitis B, meaning that we can keep the virus, the viral replication under control with PEG interferon and entecavir or tenofovir, and the oral medications are very well tolerated, but we don't have a curative treatment for hepatitis B yet, not like hepatitis C. So this slide illustrates sorry. So this slide illustrates the importance of the stages of hepatitis B. So if an infant or a young child, 5 years or younger, get exposed to hepatitis B, then more than 90% of these individuals, babies and children, will remain chronically infected with hepatitis B. And then the reverse is true. If adults or older children get exposed to hepatitis B, the vast majority of them would clear the virus. So it really shows the importance of our immune system in terms of clearing the virus. And so in developing country, most of the infections are transmitted vertically from mother to babies. In the developing country, most of it is sexually or parentally, and also by the imports from immigrant populations that have more of the epidemiology of the home country. So the US liver cancer statistics, the estimates for 2013 is that we have 30,000 new cases and about 21,000 deaths. And if we look at men in the age of 40 to 59 here, it's the number 3 cause of cancer mortality, and only after lung and colorectal cancer. And the California Cancer Registry for Vietnamese male, some of the Asian subpopulation is more affected than the others. So Vietnamese male is the number 1 cause of cancer death, much more than the Chinese and Korean patients. And there's also a large ethnic differences. So the lowest here is in the white population, 9.1 per 100,000, and the highest in Asian Americans. And much of this is due to the higher prevalence of chronic hepatitis B infection in this population. So as I have shown you earlier, clearly hepatitis B is the major cause globally and of all causes together anywhere. But in North America and Western Europe, hepatitis C is the major cause. In the US here, we see mainly hep C, but in the Bay Area, because of our diversity, we have a lot of hepatitis B as well. So we completed our registry of liver cancer, of all cancer, liver cancer presenting to Stanford in the past 15 years. So after looking at 2,100 consecutive patients, 85% of all of our cancer causes at this center is either hep B or hep C. And nationally, national data show that it's about half would be hep B, hep C. So we actually is a much more viral center as far as liver cancer is concerned than the rest of the country. Other HCC risk factors besides those major causes, hep B, hep C, and cirrhosis, is older age and the male sex, as we mentioned, and the reason for this talk. Decompensated liver disease, presence of macrodegenerate nodules and liver cell dysplasia, higher DNA levels of HBV, advanced degree of liver fibrosis, and exposure to aflatoxin, which is associated with the p53 gene, tumor suppressors gene that Dr. Wakely mentioned. This actually is more important in developing countries with contaminated grains, but it's not an important cause in the US. So going back to what we have observed so far, and very consistently and quite striking the male dominance here. And now let's go to try to see what we know and how we have been attempting to answer this. So are HBV mothers more likely to give birth to sons and therefore more HBV-infected sons? So the earlier and smaller studies show that HB surface antigen mothers, so these just includes any chronically infected mother. So surface antigen is a marker of chronic infections of any stage. Can increase the male sex ratio. And some of these show that it can increase from 105 to 150 male births per 100 female births. But a more recent and large, well-conducted studies from Taiwan, 3 million newborns. So these are 90% of newborns in Taiwan between 88 and 99. And they did not find that. They just found that there's only a slightly higher chance of having a son for HBV-infected mothers. So if we look at any HBV-infected mothers, then the rate only increased from 105 to 107. And even if we look at e-antigen positive mothers, so this is a marker for viral replication. So these mothers tend to have extremely high in the millions, billion range of HBV DNA units. It's only increased from 106 to 108. So not very impressive at all, doesn't seem to be sufficient to explain the major male dominance that we see clinically. So that's not likely. So let's go to the next question. So are male patients with chronic hepatitis B more likely to, less likely to clear infections or more likely to have active infections? So this is our registry that Marsha kind of alluded to. So this is a registry that we've been kind of putting together in the last 10 years. And this is about 4,700 patients that we register from Stanford consecutively, a few large practices with high concentration of Asian Americans in San Jose, Chinese Hospital in San Francisco, and Palo Alto Medical Foundation in Mountain View. And out of this almost 5,000 patients with a median follow-up about 5 years, we actually only have 55 patients that clear the surface antigen. So it is very rare. Spontaneous clearance of surface antigen or spontaneous cure of hepatitis B is very rare, at least in the adult populations. And in this, we actually did not find that hepatitis B is the second column there. So the rate of clearance is actually slightly higher in male compared to female, but nevertheless, the rate is extremely low, only 0.4% per year versus about 0.2% per year in female. So it's very low anyway. So how about HBV infections in male to more severe? And why is that? So sex hormones have been a subject of intense studies for decades now. So studies have shown that estrogen has a protective role against progression of HBV infection and development of HBV-associated HCC. And androgen, on the other hand, has an augmenting role in HBV transcription and development of liver cancer in these patients. And both of them seem to play this out via the interaction between the HBeAg viral protein, the HBV enhancing 1 region of the HBV genome, estrogen, androgen receptors, and the cell cycle related kinase, CCRK. And we're gonna go through some of these in more details in the next few slides. So studies show that estrogen treatment reduces the levels of HBV mRNA, and that the variant estrogen receptors, which is the primary cause of estrogen unresponsiveness, are expressed more frequently in male and postmenopausal women. And we see lower risk of liver cancer in female HBV patients who have longer exposure to estrogen with oral contraception or postmenopausal hormone replacement therapy. So somehow clinically we see that estrogen levels is protective via these observations here. So the experimental studies show that estrogen via the 2 nuclear receptors, ER alpha and beta, suppresses the HBV enhancing 1 in the HBV genome. So this is an important area, and its effect leads to suppression of HBV transcription. And also via the ER alpha, the estrogen interact with the hepatocyte nuclear factor, HNF4 alpha, and this leads to a decreased activity or even dysfunction completely of the HBV enhancing 1 region of the HBV genome, and then again, this suppressed HBV transcription. And the HNF4 alpha actually is also important in just hepatocyte transcription in general and responsible for normal development of the hepatocyte architecture. Now, on the androgen side, we see quite opposite effect. So androgen receptor is overexpressed in liver cancer, and this has been shown by many studies. And higher androgen levels are seen in male carriers with higher HCC risk than controls. And in female patients with cancer, we see a lower ratio of estradiol and testosterone. So all these are consistent with a suppressive effect of estrogen and the augmenting effect of androgen on the HBV transcription. And that could be one of the reasons why we see more male patients with chronic hepatitis B. So androgen also binds to the HBV enhancing 1 region. So in the same place on how estrogen works. And this, instead of decreasing transcription like estrogen, it increases transcription and replication of HBV genes. And it also binds to the CCRK promoter, and this increase in transcription of CCRK further enhances the androgen receptor activation. So it's sort of like a vicious cycle looping here. And androgen binding also increased. More recently, studies show that microRNA 216A transcription that leads to suppression of tumor suppressor genes, and some of these are important in the pathogenesis of liver cancer. And then again, the HBeAg also plays a role in the role of androgen here. It's a transactivator of HBV transcription, and this has been shown very consistently to play a role in the pathogenesis of liver cancer, and it increases the expression of androgen receptor mRNA transcription. So we see that there is interplay both ways of the sex hormones and factors that increase hepatitis B transcription. Now, how about the cellular damage to the liver? So those are HBV transcription. How about chronic inflammation? So when people look at the inflammatory cytokines in the development of liver cancer, they also saw some sex disparity in here. And the main cytokines that are important in chronic inflammation in liver cancer tumorigenesis is IL-6 and IL-1 alpha and beta. So studies show that inactivation of estrogen signaling contributes to upregulation of both of these cytokines, IL-6 and IL-1. And so in the case of IL-6, so IL-6 is associated with increase in liver injury and tumor development. And mouse model that ablate IL-6 expression actually reverses the carcinogenesis. And ablation of IL-6 also eliminates the sex differences in HCC development risk. So it's likely that the sex disparity probably is via IL-6. IL-1, as mentioned earlier, is also very important in development of liver cancer because it's a tumor growth factors, and it is a higher level in male. And actually, there is a linear correlation between decreasing in estrogen receptor expression and increasing IL-1 alpha levels. And there's also lack of ER expression in male HCC tissues, and these have been observed. So there are many factors that play a role in HCC development, and it looks like the sex disparity are involved in both HBV transcription as well as in the chronic inflammation and the tissue injuries caused by hepatitis B. But many of the HCC risk factors are also related to many other epigenetic and genetic changes, such as the regulation of mRNA levels by microRNAs and DNA methylation, etc. So one example of hypermethylation is the hypermethylation of the promoter region of the PP161 INK4A gene on chromosome 9 here, and it was seen to be more frequent in male. And this effect leads to tumor suppressor gene inhibition and therefore carcinogenesis in liver cancer. And one microRNA have been more studied more recently in liver cancer. So microRNA are small non-coding RNAs that bind to the conserved 3' untranslated region of their target RNA to inhibit the either translation or degradation of it. And the main one that has been best studied is the 216A. And this has been shown to associate with increase in androgen receptor expression, as I mentioned earlier, and this leads to suppression of various tumor suppressor genes that is involved in liver cancer development. And more recently, microRNA 22 was studied and associated with low estrogen receptor expression. So in summary, I am actually kind of concluding this with a bit of a downer note because we have seen very striking differences in sex difference in terms of clinical severity of diseases in both hepatitis B and liver cancer. So it kind of makes sense that there must be a target that is related to the sex hormones, and this have been studied for decades. So in the 80s and 90s, there were numerous randomized controlled trials of tamoxifen as a treatment, either as a primary treatment or neoadjuvant or adjuvant treatment for liver cancer. Tamoxifen has a higher estrogenic effect than anti-estrogenic effect. So it's expected that it may improve the survival or help patients with liver cancer. Or flutamide, which is an anti-androgen medication. But despite all the large and numerous trials, we didn't really see any improvement, significant improvement in survival with these drugs, and they never became standard of care for the treatment of liver cancer at all. So the 5-year survival for liver cancer actually still remains to be less than 20%. Some of it is because it's not really responsive to any chemotherapy that we know, and hormonal medications or target really have not been panned out. And so it is a disease that we hope to improve by prevention of hepatitis B and prevention of advanced liver disease. So hopefully in the future, we would have other studies that will focus on other targets and more likely to be immunologic or genetics. Thank you.
And thank you. That was wonderful. Any questions for Dr. Nguyen? No questions?
Hi, thanks for a great talk. I'm one of the head and neck surgeons here, and we treat a disease that is virally mediated, it overexpresses P16, and has been remarkably responsive to immune therapy. And I'm just curious, you mentioned this. Is there any hope that immunomodulation can provide better systemic therapy for patients with hepatocellular carcinoma?
Yeah, great questions. I am not aware of new efforts recently, but like 10, 15 years ago, there was some, and I never really heard from them, didn't really seem to pan out. So right now, for treatment of hepatitis, of liver cancer in general, related to Hep B or not, it's really surgical therapy by surgical resection and transplant. And there are even antiviral treatment with hepatitis C and B. It is still actually controversial right now whether antiviral therapy after whatever local treatment for it would even help. So we still don't know very much about hepatitis B and liver cancer.
Last question.
What is the possible confounding effects of alcoholic abuse between male and female incidences and outcome?
Yeah, that's a great question. So numerous cohorts and case control studies have looked at alcohol as an independent risk factor, and it has been conflicting because alcohol can cause cirrhosis, and cirrhosis of any causes is a cause of liver cancer. So some studies show alcohol is an independent risk factor, some studies don't show that. And I think a lot of it is due to the heterogeneity of the population, and that the degree of liver disease, such as cirrhosis, or the degree of cirrhosis, are probably not controlled well enough. But I personally feel that alcohol is probably not a strong risk factor by itself, other than the fact that it does cause cirrhosis, which will lead to cancer. Thank you.
Thank you.